see.
Can I go a bit backward? Dr. Can you explain to us what is CEA or AFS?
AFP.
APS.
Okay.
Yeah.
AFP.
AFP.
Yes,
And mostly, what stage we will use this CEA or
AFP.
AFP? Yes.
Well, these are usual what we call tumor markers, and sometimes you may find it in a normal screening protocol, for example, by the other, for example, healthcare companies. In general, we won't, as oncologists, we won't recommend to use these kind of markers as health screening. We only use it for those patients who are really diagnosed with a cancer. For example, AFP, alpha-fetoprotein, would be used when the patient was diagnosed to have liver cancer or sometimes germ cell cancer. They would use it as a prognostic marker to the subsequent treatment and use it as a subsequent monitoring, for example. CA may be, I would say, it's a not very specific marker. It can be used in colon cancer, in lung cancer, and sometimes in breast cancer as well. Actually, we have many others, these kind of tumor markers found in serum, say CA 19.9, which can be used as marker for biliary tract cancers or pancreatic cancers, or say 15.3, which can be used as breast cancer marker as well. All these, I would say, in general, the sensitivity is not very high, maybe around 70%. Sometimes it can be higher, for example, in PSA, for example, prostatic specific antigen, the sensitivity can be as high as 90%. The specificity can be as high as 90%, for example. But all these, I would say, in general, we won't recommend it to use as a screening tool in healthy population. In a healthy population, that's why I have a question. I have such a question to Professor: how we can apply our knowledge in TK1 in the health screening for normal population.
Yes. Maybe I can add something, because what you said is absolutely correct. 40 years ago, 50 years ago, there was a very, very big, how to say, people really would like to find specific marker for one type of tumor. And then they come up, you said AFP, CA, CA15C, blah, 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 you have a number of them. But finally we find out we do not have any good, very good specific marker. 25 years ago, PSA, prostate tumor, was coming up. And people started to use it in the health screening, particularly in North America, because they said, here finally we have at least one marker for one specific tumor. But then they found that people who has, we call nice tumor, benign tumor, they also could have high value, and also in healthy people. So, for example, in my country, we don't use PSA in health screening, but we can use it for monitoring when they already got a diagnosis, breast, prostate. Then this marker are used for, because then we know what type of tumor, and we can follow different example results of treatment. So World Health Organization has every year they're checking something new coming up, something new, but still not. So that's why when we started to talk, can we use TK1? I said no. It should not be possible, because people are testing so many different markers. No, not for health screening. And then we started to get the results. I said, my God, that's why my hair like this one, because here was something really. But we are still under investigation. We need much more cases. But so far, 160,000 cases we have analyzed. And all the time we repeat, independent research group, hospital, health screening, they come to the same conclusion. It must be something there. But to convince the rest of the world, we need more investigation. But I think we can absolutely say, yes, we have something, and here we should definitely go on and check. I promise. I promise. Okay.
Yeah. And congratulations to your work. Actually.
Thank you very much.
Yeah.
I would like to say congratulations to China, to all the doctors who cooperate with us and run this study. Thanks to the Chinese doctor who helped us. Thank you very much.